of the Mexican Center for Disease Classification, the collaborating center of PAHO. We want to thank you all for your participation to this fourth webinar and a series of workshops that we have been conducting through the Latin American and Caribbean Network for the strengthening of health information systems of Relaxis. This work is part of the working group on dissemination of the deliberate search and reclassification of maternal deaths. So in addition to having this exchange of experiences, and as I said in the beginning, this is the fourth webinar, we have had some others dealing with this important subject where we're going to be discussing the methodology. The second one was on the Mexican experience, and the third one last year was the underreporting and causes of deaths in Argentina. And all this material can be found, and it's available both on video as well as the comments that are posted on the website, where you can find all of that material available. And at this time, this fourth webinar, we will have the experience of Paraguay in the implementation of the BIRMM. We are going to have Gladys Mora and Mr. Juan Edgar Tullo, and we would like to welcome you. Dr. Gladys Ester is a surgeon, and she's a physician of the Ministry of Health, and also she is a specialist in epidemiology and sexual health, and also administrator of public resources, and currently she is technical advisor at the General Directorate of Health Programs at the Ministry of Public Health and Social Welfare, and she's also technical coordinator of the Morbid Mortality Committee for Maternal and Fetal Neonatal Morbid Mortality of that ministry. Also, Mr. Juan Edgar Tullo, he's a statistical mathematician. He's a graduate of the National Asunción University in exact and natural sciences. He is a specialist in education and in demographic analysis, and also he's the General Director of Strategic Information in Health at the Ministry of Public Health. And at the, currently, he is Director of Strategic Information, Health Information of the Public Health Ministry. I would like to remind you of the dynamics for this webinar. First, I would like to remind you, do not press your microphone during the presentation, so we will not have any interference with the presenters. The presenter will take about 60 minutes, and then we will have 30 minutes available for questions and answers. And those questions should be, you should remember that you will not be activating your microphone, but rather you'll be posting your questions in the chat room. And also remember to pick the choice directed to in the English chat room, so you can address your question to the speakers. And so that will be addressed to only the administrator of the webinars. And also, if you have any questions that we will not be able to answer because of time during this webinar, then you can write them at the website, the Relaxis page, and it will be social network, social media. The idea is that when the time is up, then you'll be able to write any comments, and you can be certain that you will get the answer to your questions. We also have the advantage of having simultaneous interpretation into English in the English chat room. That invitation and information was sent ahead of time for those of you who want to follow in the English interpretation. Without further ado, I would like to give the floor to the presenters, the director, Dr. Gladys and Mr. Juan Edgar. Good morning, can you hear us? Yes, we can hear you. Thank you very much, Manuel. This is Juan of PAHO, Paraguay. Greetings to all the colleagues, for you and all of those who are watching us. We are very grateful for this opportunity to be able to share. We have our colleagues here from PAHO and also of the department here to make a presentation. This is part of our technical cooperation program with the Ministry of Health. And the idea is of implementing strategies in order to reduce maternal mortality. One of the lines of action has to do with the strengthening of information systems, within which we include improvement of the information reported in terms of maternal health and also the estimates. And also, as you already said in the introduction, we are working together with our colleagues here, with Mr. Juan Tullo and Gladys Mora of the Ministry of Health, and a couple of colleagues who work with us here. So we thank you once again, and also greetings to our representative, Roberto Colton, who also gives a lot of priority to this area of maternal health. So without further ado, we will be getting started with the presentation. Thank you. Good morning, everyone. My name is Edgar Tullo. I'm here with Dr. Mora, Mr. Nieves, and thank you so much for the introduction. Thank you for this opportunity to all of the colleagues, to Manuel, and all the colleagues who always give us the opportunity to show what we are doing in Paraguay in order to improve registries, which is a very important issue. And also it's difficult at the same time, but it's the only way to achieve this if we work in a coordinated and in a fashion and in a team. So I will be getting started with the presentation that we have prepared. And also we have Dr. Mora available to answer or clarify any question that may come up during the presentation. Manuel, if you can help us to advance the presentation, to put up the slides.
Es el 01 y muestra un indicador hacia arriba y hacia abajo, y el número está en medio de estas dos flechitas. ¿Lo pueden ver?
Can you see the arrows? You have to click on the arrows and advance to move forward.
Una flechita abajo del 1 había una hacia abajo. Hay una flechita abajo del 1. Sí, no hay problema, le pasamos nosotros. Analizamos. A ver. Ya, ok. A lograr si quieres, para que te vean. Ok, bueno.
Very well. So we will get started. This is an outline of what we are going to be presented. We have background, the experience of deliberate search and reclassification of maternal death, lessons learned, challenges, and next steps based on the results that we have obtained during the implementation process. Very well. In order to give you some background and a general idea of Paraguay, currently we have a population of over 7 million people. Most of the population is urban, over 61%. The birth rate is 2.40%. The life expectancy is 74 years of age, and women represent 53% of the population, and adolescents, or the population between 12 and 24 years of age, is about 19% of the population. It's also important to underline that currently Paraguay has registry of about 30,000 deaths and about 150,000 live births. These are the figures that we have at the Ministry of Health. And also, in direct relation with the data that we have about 20% registry of the data. Paraguay is politically divided in 17 departments or states, and it includes Asunción as another department, so adding that to 18 total states. It is divided in two regions, the western and eastern side, where there is most of the population is on the eastern side of the country. If we can move on to the next one, please. The situation of maternal deaths in Paraguay, it's an indicator of the quality of services of health in Paraguay. And Paraguay was considered to be one of the countries that had problems in complying with MDG number 5. In 1990, had about 150,000 deaths, and according to the MDGs, according to the goal was to reduce that, so we should have reached 24.7%, and Paraguay was far from reaching that target. And also, in addition, these are registered data, so there is a big gap here in order to achieve the level that we wanted to reach. Based on those numbers, Paraguay proposed to work in improving the record keeping, and then it invited relaxes in order to apply this methodology of deliberate search and reclassification of maternal death in order to improve record keeping of maternal deaths. The challenges that we have at current time is to implement the BIRMM at all the health systems, and also there is some publications that are going to be conducted on specific study. This was commended by the interagency group because Paraguay had not published any maternal death studies, and there were no specific studies, and that the last survey included some questions about that, but that was back from 1996. So Paraguay is very much behind in this area. Another point that we're working on is to be able to identify the causes of death. Historically, Paraguay was never able to reduce to more than 10% maternal deaths. So at that time, the idea was to propose a target in order to decrease the more established causes of maternal death in all of the regions in order to improve records. Also, we saw as a challenge to improve coverage. As it was mentioned in the beginning, we have underreporting of almost 20% in the country, so that was also a challenge to increase coverage, and also joint work with the involved institutions in this work in order to improve the records and the coverage of those records, because it is important to involve the civil registry and also the census and the survey and the public ministry and the health ministry. This is the only way that we can increase the coverage of the registry of vital statistics. Also, there was something else that was pending, which was training of the medical personnel in the correct filling of the forms. We also promoted this relaxes group, virtual group, where also there were many doctors in Paraguay that were able to attend the virtual course. So this is the estimate that we had in 2015 when we evaluated the MDGs. We had an estimate of maternal death of 132 for 1,000 live live birth. As you can see, Paraguay in 2015, it had about 82.8, and it was outside of the range of confidence. That was the main reason why Paraguay has taken up the commitment to implement deliberate search and reclassification of maternal death. So based on these figures, we realize we have a serious problems with our registry and with the quality of the information. The objectives of this system is to correct the bad classification of maternal death to make it more reliable, even though we feel that our data was well recorded. When we applied the methodology, we realized there was a high percentage of deaths that were badly recorded. So this helped us in order to place a lot of emphasis on filling out of the forms and diagnosis by the doctor. So that's something that we took into account, and that's where we found that there were many causes of death that were not properly recorded because they did not have the proper information. That this has been corrected through different training that we have conducted and through the different services that we have provided, where there used to where we found problems with the correct filling of the forms, or there was a bad classification, wrong classification of the information systems. Also, we've been working with the administrator and managers in order to be able to have a more, to be empowered to work in this maternal health area, and also to work together with all the different levels. So through this study, we're able to work with all the committees so they can do that search and they can take on a better commitment in order to improve registries. And we did this together at every level. So what is it that we expect from the BIRMM? To be able to recover the cases of maternal death cases that were not registered as maternal cases, also to improve the classification of basic causes of death, greater reliability of data, to publish annual reports, to strengthen maternal death committees, and to improve annual estimates made by the interagency group. Even though everything is here on the screen, even if we are able to accomplish all of these points, we're certain that the interagency group will be able to revising the estimates for the country, but we have a long way ahead in improving all of these points. It's starting in 2015 as a country, we took on the commitment to implement the system, and we're doing this on an ongoing basis so far. So we are also trying to complete the publication of an article on deliberate search for 2016-2017, and this would also help for other countries to be able to know the work that is being done in Paraguay in this area. The BIRMM structure, we have been working with 3 different offices of the Ministry of Health. We work with the DPG, which is the Maternal Death Committee, and all the local committees. Also, the General Directorate for Health Surveillance, where the mandatory reporting of death must be made, and also the DGVS, which is in charge of collecting all the information and keeping historical records, and keeping the health records of patients, and all the information that would help us to gather more information and to improve the registry of maternal deaths. So what we did was to standardize the methodology for suspected concealed cases. Since 2015, we have a single death certificate, and it has been implemented in all the private and public health establishments. This helps us to have information from all the country. That information is available through an information system which is online, and we can corroborate it automatically as long as that information has been recorded in real time. In order to have the database, we do the validation and the monitoring by another office under the ministry. They are in charge of validating that information from day 1st of the following year. They start working in order to have that information available about 6 to 8 months after the end of the year. The BIRMM is implemented at the national level and is disaggregated by health regions and by health services. As I said, we have 18 different health regions. And also, there is a distribution of suspected concealed cases based on the selected numbers and the criterion of suspected cases. We're having some audio problems.
Ahora. ¿Ahí me escucha?
Can you hear me now? So, as I was saying, so there is a distribution of suspected cases, and also based on the numbers of selected cases, which is based on a list that we take from PAHO that was also analyzed by a group of doctors in order to be able to add any other causes of death which could be concealing a maternal death. So we use that list of 61 cases in order to do that verification. How do we work in order to make this work interactive? The first thing, we start with collecting the data through the system that has been implemented in all the health departments, and then it is charged through an informational software through the information system where we do the verification and control and consistency of the data. Then we review all the consistency of data for codification, and we match it with the data of deaths. We also extract suspected cases out of all the cases, which is about 600 cases, and this is reviewed by the Committee of Maternal Deaths in order to include or exclude cases. Once all this process takes place, it's sent back to the Strategic Information System of Health. The necessary changes are made in order to close the whole loop of the deliberate search. The committee double checks whether it's a maternal death, and it will send the reclassified cases to the General Strategic Information Service, and then it matches or verifies the final diagnostic information system, and then it will keep it based on that after it has verified. This is the whole process based on all the work that has been done. What do we have as lessons learned? What we still need to work is on the implementation of this whole process at the local level. Nowadays, this is only working at the central level, and the central level will go out to visit the local departments, because where there is a health department that is working on a case-by-case, depending on the number of suspected cases that each institution has. We also have a problem where we're trying to start a deliberate search ahead of time in order to increase coverage. We started this back in March, and the work will be completed. It's completed usually between August and September. But since during that time, we still don't have 100% coverage of all of the cases of deaths, so this makes it a bit difficult to reach coverage of 100%. We want to include more human resources in this committee. At present time, we only have 4, perhaps 5 people working in that committee, and this makes the work a little bit slower. So the idea is that starting in 2018, one of the intentions is to increase the number of personnel in order to improve processes. Also, I wanted to mention about the feedback and the results that we have had in the health services. This is the only way for us to know that the work has been done and to be able to be more empowered in order to make the necessary improvements, and also for the people themselves to be multipliers of the services. So this is something that we want to do throughout all the local services, of course, by empowering more human resources. We also want to train the local resources at the local level, also the maternal death committee at the local level, so they can do outreach and they can help us with collecting information. We want to increase the coverage of about 95% of expected cases. This will require increasing the number of registries for deliberate search. We also want to include all of this into the data system in order to have more accurate information. Nowadays, the database was closed as of September of this year, but according to the national plan, it says that it has to be done by June of every year. So we want to improve the collection of that data, so we can shorten the time for collection of that data, and we can do that as long as we have human resources. Also, we want to improve all the data, the publishing of the data. The intention here is to be able to publish those on an ongoing basis. Also, we want to improve the register and death certificates. And so far, we have obtained very alarming results in regard to the registries that are available. So we want to work in improving the recording of maternal deaths, because we have a poor classification of about 20% of the recording or registry. Now, we also have limited availability of clinical history in order to investigate maternal death. About 20 to 25% of cases cannot be matched against the data recorded. This can be improved by working with the local community and by empowering the local people, so they will feel the need to improve documentation. Not only to improve recording, but also this would improve all the indicators. So this is something that we also want to work at the community level in order to be able to implement all this information at every level. Results of the search for the 2015 study shows us that out of 2,800 maternal deaths of childbearing age, which were included among the suspected cases, 497 cases were studied, and they represent about 27%, out of which 94 cases they were not studied and documented, which was one of the problems that I was mentioning before. 60% or 97 cases were ruled out, discarded by the committee, and then those that were included were 108 cases, confirmed cases, which account almost for 22%.
Of these, 74 cases were completely concordant, 21 were reclassified, and 13 cases were late. And so beginning in 2015 with the intentional search, we're reporting on maternal deaths. So this was the entire process for 2015, and in the next slide we can see what occurred in 2017. Now in 2016, we have 2,339 women in reproductive age. 63 were classified as suspicious. 158 weren't studied, lack of documentation. And there were a number of cases of death with no certification. 405 cases were eliminated, discarded. 110 cases confirmed. Now the sound is not coming in clearly. Next slide. Again, the sound isn't clear enough. The slide refers to maternal deaths in 2015-2016, the number of cases of maternal deaths, the number of those found with the search method, and the total number of maternal deaths. There doesn't seem to be a technician available, at least here at PAHO headquarters, to correct the problem with the sound. Here you can see the data over time. The speaker is being interrupted, pointing out that there's a problem with the sound. It may be a question of how the microphone is being used.
También las laboratorios iniciamos hemos escuchado también algunos inconvenientes de lo que seguimos. Sí, hay un inconveniente. Ok, entonces que característica lo que queremos mostrar es cómo ha evolucionado.
Now here we're showing the number of recorded maternal deaths from 2008 to 2017. Now, this reflects the situation of this indicator in Paraguay, and we're working very hard. And we're hoping that the interagency group will be able to undertake the necessary revisions, and so that we have numbers that are closer to the reality. But we also need to improve the records. So what is our commitment based on this information? Well, the first commitment we had worked on with the team was to reactivate the National Council on Vital Statistics. This council had been set up in 2003, and the different ministries were involved. But now we want to amend the regulations, and we want to include other ministries, because the forensic physicians also play a very important role. So it would now involve the Minister of Health, and the minister had already requested the capacity to work with these other ministries in order to improve the records. So we're going to amend the article and in this way try to improve coverage. We will continue with virtual training. This is a commitment of the government. And we expect a larger number of physicians to participate. Now we have approximately 1,000, but we want to increase that number by 70–80%. And this will also help for performance evaluation. We also want to undertake on-site training in a number of regions that are considered to be poorly defined. And these are areas where we see 3 or 4 times above the average. And so this is where we wish to undertake on-site training. And this will be accompanied by the virtual training. We have a CIE use in the training courses. There are some areas that do not have the equipment. So what we need to do now is find out what is available. Now we also, at the local level, need to stress the importance of the quality of the data in terms of information and timeliness. And we expect to have the data in real time, and in this way we can look at the suspicious cases and undertake a more thorough analysis. We want to unify the database, and we want modules for analysis and reporting for all of the users of the system. So we want to unify the system, and so the process become more automatic. And we also hope that we can improve both local and regional levels, and so that there is appropriate follow-up. So this then is the summary of the process we began in 2015. The first meeting was held in Mexico, and we then committed to implementing the system in Paraguay. Yes, we have many problems, but we move ahead slowly but surely. And our intent is to continue with the process so that our numbers truly reflect the situation. And of course have a better indicator, and for Paraguay to become an A country, and that the recorded number be the real numbers and the official numbers. Well, thank you very much, and I await any questions. Thank you very much, Edgar. There's a question from Olga in Costa Rica. She asks if the interagency estimates are far above the national reality. It is something you mentioned. If you hear me, yes, I will answer the first question. Yes, please go ahead. As a statistician, I believe the figure is consistent, because undertaking a quick exercise, so the under-recording had to do with poor classification. So as a country, if we don't increase coverage and if we don't get rid of the bad classifications, the figures are not going to reflect the reality. So we need to work on coverage, on the quality of data, and the estimates then will be more accurate. Does Olga have another question? Now, did you do a sample or all of the suspicious deaths? This was hospital deaths as well as deaths at certain health centers. Well, I commented on this. One of the challenges for the team is to have 95% coverage. The work began in February, March. At that time, we had a record of 20,000 deaths. But the fact is that there are 30,000. And why do we know this? Because there's a lack of data. Private hospitals and the Social Security hospitals continue to provide data, but they don't have the capacity to load it all up for the Ministry of Health. So what this means is that we do not have an approximate figure to have an accurate figure for suspicious cases. So once we closed the search, the number of cases for the search was close to the 2,000, and when we closed the database, we found 2,200 deaths of women of childbearing age. Now, we could say that what we have is a sample when we began our intentional search study. Very well, thank you. Rosa Lopez has a comment. And the comment has to do with including training under performance evaluation. And our colleague Olga also has a question. Sorry. Can you explain the lack of documentation? Again, the sound is not very clear. Lack of documentation. Why is there a lack of documentation? What is the explanation? Good morning. I am Dr. Mora. I am the technical coordinator of the committee. And once we had the figures on suspicious deaths, we began working with hospital services and different health regions. And what we found was a great weakness in that there was a lack of specific data in the clinical histories and the tools which we feel are valid in order to undertake a case review. So when we began with this problem, we felt that the main tool would be an accurate clinical history. So we began to work with health services, and we found that there were different ways of recording the information from the patients. According to the pathology the women showed who came to the clinics, and we had other tools which have been used for clinical history. We had notebooks, we had care sheets, which were for purposes of evaluation for incoming patients and for emergency patients. And what we found is that the quality of the information was reduced. And what we found is that there was some information not included. Which made research very difficult. Another restriction was that the women coming into the services often suffered from certain pathologies, but they weren't necessarily gynecological. So essentially, the physician would not identify certain risks.
En que podría estar embarazada. Esos datos específicos como antecedentes de planificación familiar, antecedentes de embarazo o antecedentes de aborto, no figuran.
Very often, when there had been previous miscarriages, this was not included in the clinical history. So we were unable to close the case. Now, there were some cases that look more doubtful. There were also, she refers to something as a verbal autopsy. Now, these are cases that certainly show us that we need to work much more on training our human resources. And if we take these women from 10 to 54, who may become pregnant, and what are the specific questions that can be asked by someone who is not a specialist in gynecology obstetrics? And that what could be understood is that there may be a pathology that is either associated to a pregnancy or not. I don't know if I've answered the question. Right now, nothing can be heard. The sound is way too distorted. The interpreters cannot hear the sound. I don't know if the other listeners can hear the sound or not.
En el marco de un grupo con la DGE y C y ustedes mismos con el RC, pueden recuperar probablemente la cobertura en un futuro próximo. Bueno, esto más bien es.
Will you be able to improve coverage in the near future? And Rosa Lopez, have you considered a recommendation regarding human resources? And this goes to the turnover. And what do you do to avoid turnover? Why a lack of information in the cases not studied? I believe that was answered when Olga asked the question. So that's been answered. And Miguel also asks, how do you select suspicious cases? This was a good point. I had a question here because Edgar mentioned that there was a PAHO proposal and there was experience in Mexico. The sound is insufficiently clear for interpretation. We took the 55 suspicious causes suggested, the list of suspicious deaths, including maternal death. So there were 55 according to PAHO. And there are 6 additional causes defined by a committee in 2015. So we had suggested adding them, such as lupus, kidney failure, septic shock, And we're a country very much affected by dengue, so we also wanted to consider dengue as one of the suspicious causes for maternal death. Well, thank you very much. A question regarding the age range. Manuel is being told that he cannot be clearly understood. We're not receiving sufficient clarity. Is that better? No, it isn't. What was the age range considered for suspicious deaths? The age group was between 10 and 54 years. Again, the moderator is indicating that the sound is not clear enough. It had been all right, but it worsened. Maybe some of the comments can be written down. The sound is worsening. Maybe the questions can be written down. Yes, the questions will be written down. The problem has to be with your response to us. So the questions will be written down. Sorry, can you hear me? In order to answer the question, one of the challenges is to work together and to reactivate the National Council on Vital Statistics. They're not involved in the search process, nor is the public ministry or the Ministry of Health. So we want to reactivate the National Council on Vital Statistics so that they can participate and increase the coverage of all of the recorded cases. Now, this is very important because this is something that will allow us to increase coverage quickly. Now, as Edgar and Gladys said, when it comes to data gathering and how to improve the sources of information, efforts are underway. So here what we would have is vital statistic data. What we need is improved data processing and improved reporting. Then what we have is analysis and classification. This falls under health programs. And the technical team undertakes the work of reclassification or confirmation of maternal deaths detected as reflected in the database. Thank you. Can you now hear me better? Well, no, we can't hear right now.
I posted the question in the chat.
Nosotros en este momento.
At this time, we are not in the process of studying maternal death by different causes. Basically, what we are notifying, yes or no, whether we are in the analysis of maternal deaths by cause.
Y estamos en el proceso.
And we're also in the process of including that. We started in 2015. We started with late maternal death, and we're also in the process of including the different causes of maternal deaths. I'm trying to reconnect here. Can you hear me better, Juan? Can the other participants hear me? Or is it only your connection? Are you the only one having difficulty? Yes, I heard the other speaker. I could hear the other people. It sounds like it's on our microphone here. Well, let me give you a comment by Maria Rosa, who put it in the private chat. It says, on the request by Rosa Lopez regarding asking for the age of the different women in childbearing years. It says for international comparability, we should use the international PAHO standards. But is it possible for us to use that range between 10 to 54 years of age in a country? We have to take a look at the number of pregnant women and also live births. Also, the number of pregnancy in young girls can be very high, also in women who are 50 or 40. Just for the purpose, for international comparison purposes. What will be your comment? Well, what we have done is that we use that age range because, unfortunately, we have very young girls getting pregnant. And so the purpose of deliberate search, and by doing this, we have found that maternal death also in different ages, even 50 years of age. So we decided to continue with that age group, so that we're trying to strengthen this process. And that's why we are using that age group that we're studying, between 10 and 54 years of age, which is very important for us to follow. Can you hear me better now? Well, as we have proposed all the questions that are still pending, if you can put them in the chat, they will be answered later, as we said earlier. Also, the presentation and the slides will be available, and we want to thank Dr. Edgar Julio Gómez and Dr. Ester Mora for the presentations. We would like to invite you to follow us on our website, and also to announce that this coming Thursday, 18th of October, we'll have our webinar number 5 and the last one in this series, where we'll be sharing the experience of Dominican Republic in the implementation of this system. So we want to thank you very much for your attention.